Hi, my name's Stephen. I'm a neurology registrar from South Australia, but I'm currently working at the Massachusetts General Hospital in Boston, so I'm sorry I couldn't join you all in beautiful Adelaide today. I'll keep this relatively brief because I know that sometimes watching recorded talks can be a little bit taxing, but we're going to be talking about artificial intelligence in the diagnosis of allergic diseases, and in particular with a focus on our experience, because we have been doing this, and I think we've picked up a couple of lessons along the way that might be useful to other people. So artificial intelligence is everywhere at the moment. I'm sure everyone's getting tired of hearing about it at times and its purported benefits and clinical utility. But I imagine that fewer of us are actually seeing that clinical utility, except for maybe AI scribes, but that's a whole different kettle of fish. That's another talk. Where is the utility? Who's using it? There is an implementation gap in clinical artificial intelligence that is a mile wide. It's probably best in radiology, but really, even there's some significant issues. So, why is that? I mean, multiple people have written and spoken about it, but ultimately, it's because a lot of the algorithms that are being made, they're predicting something that's blindingly obvious clinically, or the time at which the prediction or the classification is being generated isn't clinically useful. Really, you need a use case where the AI can do it and it can add value to the clinicians in the clinical workflow. So that's what we did. We had a problem, we've developed algorithms, and we've used them and evaluated them. And now I'm going to hand it over to Mel to talk about our experiences with that. So take it away, Mel.
Hi everyone, my name is Jiang. I'm currently a dermatology service registrar at the Royal Adelaide Hospital, and I was previously the drug allergy RMO within the immunology department at the RAD last year. Thank you very much for this opportunity to present a prospective implementation study entitled EPAS-ML. This study investigates the implementation of a deep learning facilitated proactive penicillin allergy delabeling program. And I'd like to start off by thanking and acknowledging my co-authors, in particular Associate Professor William Smith and Associate Professor Stephen Bacchi, for their supervision of this project. As we know, penicillin allergy labels are common, they're often incorrect, and associated with significant health and economic costs. It's estimated that approximately 10% of inpatients carry a penicillin allergy label. However, when tested, 90% of these patients are found to tolerate penicillin and can be safely delabeled. Our previous studies have shown that having a penicillin allergy label is associated with worse outcomes for inpatients within the Central Adelaide Local Health Network. Patients are more likely to be prescribed alternative non-penicillin antibiotics, which often have unnecessarily broad antimicrobial coverage, increasing the risks of antibiotic resistance and C. diff infection. Having a penicillin allergy label is also statistically significantly associated with an increased length of stay of greater than or equal to 7 days, as well as increased rates of readmission and post-operative complications. So what is the best way to delabel these patients? Currently, the majority of penicillin allergy delabeling is carried out by specialist immunologists within the outpatient setting. However, a recent Australian exploratory economic evaluation by Brusco et al. Found that penicillin allergy delabeling is actually far more cost-effective when conducted opportunistically within the inpatient setting, as that leads to cost savings through reduction in follow-up consultations, opportunity cost, and also car travel costs for patients. However, in current practice, penicillin allergy labels are rarely evaluated during the inpatient admission, and as a result, these patients are rarely referred to the immunology service for consideration of delabeling within the inpatient setting. Such referrals are often initiated by the treating team only on a reactive basis when prompted by a lack of alternative antibiotic options available. The implementation of a specialist service that proactively identifies and triages inpatients with penicillin allergy labels on an opportunistic basis is one strategy that can be used to increase the rate of penicillin allergy delabeling. However, as you can imagine, in an 800-bed hospital with high inpatient turnover, manual screening of the EMR to be able to identify and risk stratify all penicillin allergy labels, to be able to identify potential delabeling targets, is a time-intensive activity and therefore challenging to be able to actually feasibly implement. So in this study, deep learning was used to facilitate the efficient implementation and risk stratification of patients with penicillin allergy labels who are deemed likely amenable to delabeling. This subset of patients identified by the algorithm are offered access to an opportunistic inpatient penicillin allergy delabeling program or the option to pursue outpatient delabeling. The objective of the study was to determine if this proactive machine learning facilitated penicillin allergy delabeling program will reduce the number of individuals with incorrectly labelled penicillin allergies. This was a single-centre prospective study conducted over a 14-week study period in the RA. The electronic medical record utilised in this hospital is Allscripts Sunrise, which has a dedicated section for adverse reaction labels. All patients included in the study were over 18 years of age, admitted on a screening day under any service during the study period at the RA, and had an allergy label in the EMR to one of the several nominated penicillin antibiotics. The historical control group included 318 inpatients identified over a 20-week study period with a penicillin allergy potentially amenable to delabeling. The purpose of this control group was to determine the baseline rate of inpatient penicillin allergy delabeling, that is, prior to the implementation of this proactive delabeling service, and reflects the current standard of care. Patients in the control group are still able to access inpatient delabeling through the immunology consult service as usual, if requested by the treating team. This historical control group was previously published in Stretton et al. 2023. Patients in both the intervention group and the historical control group were identified by applying the previously derived machine learning algorithms with an area under the receiver operator curve of 0.988 to systematically identify RA inpatients with penicillin allergy labels who may be suitable for penicillin allergy evaluation. This algorithm was previously described in Inglis et al. 2021 and involves a 6-layer artificial neural network. It classifies documented adverse reactions through text pre-processing involving negation detection, word stemming, and also stop word removal. The algorithm determines whether an adverse reaction is likely an allergy or an intolerance, and for allergies, whether it is high or low risk. These classifications were utilised as previously defined using expert criteria. To minimise false positive delabeling target results, the study implemented conservative algorithm thresholds. External and practical validation of these models was subsequently reported in Inglis et al. 2023. The models were validated on 10,346 penicillin allergy labels and demonstrated a sustained high classification performance with an area under the receiver operator curve of 0.99. The models performed comparably with expert criteria for the categorization of allergy versus intolerance and identification of high-risk allergies. For patients who were assessed as being suitable for an oral challenge, the following dosing protocol was used. This involved administration of 50 milligrams oral amoxicillin followed by 500 milligrams oral amoxicillin after a 1-hour period of monitoring, and then subsequently 3 days of 500 milligrams oral amoxicillin TDS. So in terms of what this actually looks like when integrated into the clinical workflow, once the algorithm identifies a potential penicillin allergy delabeling target, my role as the drug allergy RMO was to screen the patient's electronic medical record for eligibility, then contact the patient's home team to determine if they met any of the exclusion criteria. If the patient was eligible for inclusion based on screening, I approached the patient for enrolment. For all patients consenting to further in-person allergy evaluation as part of the oral penicillin allergy delabeling program, I undertook a structured penicillin allergy history using this standardized form. Based upon the structured allergy history, the validated beta-lactam antibiotic allergy assessment tool, the AAAT, was applied to facilitate assignment of a standardized phenotype and management option depending on the clinical manifestations of the index reaction. In cases of uncertainty, I discussed individual cases with an immunology specialist to determine the most appropriate management option. All patients enrolled in the oral penicillin allergy delabeling program received individualised education on the significance and implications of their penicillin allergy label and were offered options to facilitate delabeling, as well as the option to decline further testing. Depending on the clinical phenotype, one of the following management options were undertaken, which included either undertaking the oral amoxicillin challenge as an inpatient or direct delabeling without further testing if appropriate. Alternatively, the patient was referred for outpatient testing. For patients successfully delabeled during the inpatient admission, they were able to commence a penicillin-based antibiotic for therapeutic purposes in the same admission if required. In the first 3 months of implementation, we found that 92% of patients identified by the machine learning algorithm and who met inclusion criteria were enrolled in the oral penicillin allergy delabeling program. Of the 46 patients enrolled in the program, 43.5% were delabeled as an inpatient. That included 11 patients who were directly delabeled without testing, and also 9 patients who were delabeled through inpatient challenge. Additionally, there were 26.1% of patients who were referred for outpatient testing, and there were 11 patients enrolled in the program who did not wish to undergo any further evaluation. And there was 1 patient who was referred to the immunology outpatient clinic for further specialist evaluation. 1 patient's penicillin allergy label was revised, and 1 patient was not suitable for challenge as she was concurrently enrolled in a clinical trial. In terms of overall safety, there was a 100% challenge pass rate and a 0% adverse reaction rate. This study has limitations, including its single centre status, and another limitation is the use of a historical control cohort with a lack of randomisation. Overall, the delabeling rate was limited by a number of different factors, including multiple patients who were discharged prior to the first opportunity for review, for instance, patients admitted for day surgery. We also did not examine relabeling rate within this study. So future research should aim to substantiate our preliminary findings from this study using a multi-centred study with longitudinal follow-up to determine the rate of relabeling. In summary, this study demonstrated the successful use of deep learning to facilitate the efficient identification and risk stratification of patients with penicillin allergy labels. Of the patients offered the opportunity to enrol in the program, 96.6% agreed to enrol, indicating a high level of patient acceptability of the program. All inpatient treating teams were also contacted prior to patient enrolment, and 100% of the teams also agreed to enrol their patient in the program, and that indicates a high level of clinician acceptability. Additionally, there were no adverse reactions during the study period, and that supports the safety of this program. The overall inpatient delabeling rate was 16.5% of the 121 patients identified by the algorithm, and that's a substantial improvement from the rate of inpatient penicillin allergy delabeling at baseline, which was 0% in the historical control group. Furthermore, from a funding perspective, this program is likely to be self-sustainable as it's projected to result in significant future savings in terms of reduced length of stay, optimised antibiotic utilisation, and also reduced complication rates in future hospital admissions. Thank you very much.
Thanks, Mel. Stephen here again. I think this is really exciting personally. This is artificial intelligence improving patient access to antibiotics. This is really clinical use of artificial intelligence, and it works. We've learned a few things along the way that might be useful for you, hopefully. So one is that how to conceptualize this process. I think about it like a clinical decision rule, like the Ottawa ankle rules. There's a whole literature around this, a lot of it written by Ian Steele from Canada, where you derive a rule, you validate it, and then you implement it. And then you do post-implementation monitoring. Now, there is artificial intelligence literature around this, and they use terms like validation slightly differently sometimes. But ultimately, clinicians first, I just find this a useful structure. Second point is that a lot of artificial intelligence research is using what is in the electronic medical record as the ground truth. And I think having worked in hospitals, a lot of us can remember times that what was written in the electronic medical record was fairly wrong. I think it's just something we need to be mindful of, the limitations of EMR data, particularly when you're looking at things like predicting readmission, predicting deteriorating patients. And then finally, the way that you implement these algorithms matters. You could have the best algorithm ever, but if you do not implement it well, it's not going to help patients. So in this series of studies, we had one study that used an email notification, and it resulted in around 5% of patients being delabeled. You compare that to the study that Mel just presented, there's a significant difference. And this is where I think we really need clinicians who understand artificial intelligence to help guide these studies. Because if you've got a great algorithm, you want it to deliver the best possible benefits for your patients. And that's what we're studying now. So in the Weill McEwen Hospital and Modbury Hospital, which is where I work when I'm in South Australia, we now have a system that text messages every trainee medical officer at the start of each day with a series of updates about their inpatients. And you can see there it's got things like Met call overnight, new CT result overnight. Out of interest, this has actually been shown to improve inpatient constipation, dysglycemia, and use of some intravenous medications. And now we're also using it to flag antibiotic allergies that could potentially be interrogated using these same algorithms. So this is ongoing work. We haven't evaluated the results of it yet, but I'm optimistic that it will also show a benefit. The question is then where to next? So we plan to use this throughout South Australian public hospitals. We'd be really interested in working with other sites who have different electronic medical records as well, because the text in the electronic medical record should be agnostic, so the algorithm should be agnostic. Getting the actual text out of an electronic medical record and the technical considerations around that do require a bit of work, but I think this is providing benefits to patients, and I hope that it can provide benefits to as many as possible. So this is what artificial intelligence produces when you ask it what artificial intelligence improving access to life-saving medications looks like. I'm just excited that we found a really good way to solve this clinical problem, or at least contribute to the solutions that are affecting this clinical problem. And I hope you found it exciting and useful too. Thanks.